Y gracias Asunción y Gustavo por invitarme y mucho gusto a todos. Me da mucho gusto estar acá con ustedes. Pues hablando de un tema sumamente relevante en este momento, ya que el panorama legal del aborto va cambiando minuto a minuto. Deja nomás compartir mi pantalla.
Ahí está.
Y a ver. Slideshow, así es. ¿Ustedes pueden ver la dispositiva?
Sí, aunque la vemos en chico. Bueno, sí la vemos. No sé si la quieres agrandar o así.
Se ve muy pequeño, si lo puedes poner en modo de presentación, mejor.
Ok.
Presenter view.
Presenter view, a ver.
Sí. Ahí. Ah, no.
¿Ahí mejor o igual?
No, está igual.
Está igual. A ver. Deja ver cómo hacer esto. ¿Están viendo las notas o nomás la
Sí, estamos viendo
vemos las notas.
Las notas, sí.
Ok. A ver. Ahora igual, ¿cierto?
Sí, igual.
Ahí.
Cambio de fondo.
Sí. Ay, ¿qué está pasando? ¿Me dan 2 minutos?
Claro.
Ok, ahorita vuelvo. Voy a pedir ayuda, perdón.
Sí.
Creo que la opción es la segunda que dice play from current slide.
La otra sería en la parte inferior de la página junto a donde se agranda o no el diseño, ahí donde está el mismo icono, es más fácil.
Ah, sí, es cierto, está abajo.
O a veces con que le pase a otra diapositiva, como que ya, pero le tiene que pasar a la siguiente.
No, hasta abajo está el iconito de presentación, como dice Bernardo.
Ya. ¿Ya mejor?
Sí,
perfecto.
Gracias.
Sí.
Perdona la tardanza. Pues sí, con su permiso voy a dar la ponencia en inglés para que vaya más suave. Así que, como dijo Asunción, hoy día hablaré de los hallazgos de un estudio que realicé en la Ciudad de México después de que se despenalizó el aborto en 2007. Y sobre todo voy a enfocar en lo que es un capítulo ya del libro que se trata de encuentros entre pacientes y proveedores del aborto en las clínicas de ILE. Así que he puesto el título Reproducing Responsibility, Abortion Rights, and Reproductive Governance in Mexico. Around 56 million abortions are induced across the world each year, making the procedure a common aspect of women's reproductive lives. Despite its global prevalence, abortion is arguably the most controversial medical procedure that exists, representing one of the most loudly contested public struggles in the contemporary global arena. Of course, in the United States, where I live, Roe versus Wade was overturned last June, reversing nearly 50 years of constitutional abortion rights. And this is just one example. And while abortion rights are expanding across certain parts of Latin America, Mexico, Colombia, Argentina, y así, almost 97% of women in the region live in countries with restrictive abortion laws, and the procedure is banned entirely in 6 Latin American countries. And it's no secret that criminalization does not stop women from terminating pregnancies they cannot bear to term. Harsh laws push women to obtain illicit and sometimes dangerous procedures, driving up associated morbidity and mortality. Latin America, as many of you likely know, has the highest rates of abortion in the world, with as many as 6.5 million abortions induced there annually. And even though this procedure is remarkably safe when performed in adequate conditions, around 760,000 women across the region suffer entirely preventable abortion-related injuries each year, amounting to what some scholars have called a clandestine epidemic. Como bien saben en este llamado hoy día, before a string of reforms loosened constraints on the procedure in the Mexican capital in the year 2000, Mexico City's abortion laws had not been revised for decades. And this punitive and legal environment has made unsafe abortion the fourth cause of women's death nationally. But of course, the deadly burden is borne most by the poor, racialized, and young. So abortion in Mexico, like elsewhere in the world, is what Adriana Petrina and Carolina Fullis have called a fault line of survival, a fault that cuts across the country in such a way that the poorest, least educated, and/or indigenous women are 9 times more likely to undergo an unsafe abortion than their wealthier, more educated, and non-indigenous counterparts. So this study was based in the aftermath of the 2007 reform that decriminalized abortion in the Mexican capital, transforming abortion into a legal right of women, and making the procedure available on demand and free of cost through La Secretaría de Salud. Obviously, the reform was a watershed, catapulting Mexico City to the vanguard of reproductive rights in Latin America, making it one of just 3 places in the region where elective abortion was permitted at the time. And while this landscape of reproductive governance in Mexico is fast changing, at the time of this research, Mexico City was the only place in the country where elective abortion was legal. So we can think back to that moment immediately after the reform, which is when I conducted this research. Feminist advocates and scholars in and outside Latin America celebrated the 2007 abortion reform for ushering in a fundamental transformation in the relationship between the Mexican state and women as subjects of abortion rights. They described a monumental victory for reproductive rights and a new moment for the construction of women's citizenship. But as a medical anthropologist, I set out to examine the very place where Mexican women were laying claim to their new reproductive freedoms, the Yle Clinic, and how dynamics of clinical care across the Yle program shape processes of women's citizenship after abortion reform. So some of the overarching research questions that motivated this study appear on the slide. I wanted to understand how women, abortion providers, and ordinary people were interpreting this new element of public health care in the Mexican capital, how they reconciled abortion decisions that defy church teachings given their own religious commitments or moral misgivings, and how women were navigating Mexico's fractured abortion landscape. To explore these questions, I conducted a 19-month ethnographic study, primarily in 2 of 4 public Yle clinics. I carried out in-depth interviews with 60 abortion patients or women who arrived at the clinic to interrupt their pregnancies, 15 abortion providers, nurses, social workers, doctors, and pro-choice activists in the city who helped to get the reform passed. And though I won't talk about it today, I also conducted research in Guanajuato with Las Libres, who provides self-managed abortion in a context of extreme legal restrictions, as I'm sure many of you know. The extension of abortion rights in the capital has afforded new reproductive possibilities for hundreds of thousands of women and averted immeasurable suffering. It's hard to overstate the significance of these outcomes. Yet, while the 2007 reform is celebrated for ushering in a transformation in women's citizenship, I found that dynamics of care across the Ely clinics reinstate familiar styles of governance that have long been central to Mexican reproductive policy. As we'll see, Ely providers regularly chided women seeking abortion to be more responsible in their reproductive lives, perpetuating messages that echo a long history of Mexican sexual health campaigns designed to instill citizens with responsible dispositions. So if I can condense the study argument down to one concise phrase, it might be what appears on the slide, that the extension of abortion rights in the capital has both opened new avenues for reproductive care while also expanding agendas of Mexican reproductive governance. So let's take a look at how this happens in practice. The following scene from my fieldwork represents a typical morning inside the Ely clinic. 20 sleepy patients lined the waiting room of Santa Marta, a pseudonym, a public abortion clinic in the heart of Mexico City. Many families had arrived to the clinic as early as 4 a.m., moving across the city in the pre-dawn hours to obtain one of the limited appointments. They'd pushed through the regular aggregation of protesters outside the clinic, claiming a place in the long line that stretched forth from its front gates. As the wait dragged on, Roberta, a clinical social worker, instructed the patients to maintain silence. I watched this scene unfold from within the counseling office, where Roberta prepared for the daily round of intake interviews. Resigned to the noise, she called in the first patient. "What happened, Aramis? Why are you back here again?" Aramis, the woman, stared blankly as she took a seat, sensing that the question was rhetorical. "How are you taking care of yourself when you became pregnant?" Roberta asked. "The condom," the young woman said.
One thing, we're not watching anything. Are you presenting something or just talking?
Just talking, porque
Okay,
es una viñeta, así
Okay,
que
thanks.
para el efecto dramático tengo la
Okay.
pantalla cerrada. But you didn't actually use it, right? The condom. Roberta's tone betrayed her cynicism. "You're here for your second abortion," Roberta continued, scanning Aramis's medical file. "You have 3 kids, you're a single mother. Who's going to take care of your kids if something happens to you? Abortion is not a joke. It's your health you're putting at risk. You have to be more responsible. Which contraceptive method are you going to choose so that we don't see you back here again?" Aramis took the scolding stoically, deciding on the implant before moving back to her seat in the waiting room. And this exchange was fairly standard according to my findings, where, as we'll see, clinical encounters in Ely clinics work to fashion responsible reproductive subjects in accordance with established modes of Mexican reproductive governance. So for medical anthropologists Lynn Morgan and Elizabeth Roberts, this term I keep using, reproductive governance, describes the ways in which a variety of institutions and actors, the state, the church, use law, moral edicts, and sometimes direct coercion to regulate reproductive behavior and manage population dynamics. These mechanisms can take overt form, such as population control campaigns or abortion bans, but they can also be enacted through more subtle modes of moralization of people's reproductive decisions or behavior, for instance, in clinics. And I'm building here in this talk on perspectives in medical anthropology that analyze the clinic as a key site for the production of political subjects. So medical anthropologists approach doctor-patient interactions as loaded exchanges that produce political and subjective transformations that resound far beyond the clinical encounter. And finally, my arguments here are rooted in a newer body of work that critically analyzes the rise to dominance of rights-based approaches to social justice and reproductive equity. So despite the growing traction of human rights discourse across the world, critical legal scholars and legal anthropologists have begun to point to the ways in which human rights are embattled at the local level and also to their potential for co-optation. So a critical perspective on human rights appreciates the ways in which human rights can be emancipatory, but also constraining, especially as they're channeled through the established legal process and formulated in state law. So as we'll see here in the aftermath of abortion reform, I'm trying to show how dynamics of care in the Ely Clinic extend norms of good and responsible womanhood rather than challenging them. La pantalla es blanca, y es a propósito. When I got a chance to speak alone with Aremis, the abortion patient I mentioned, she told me that her pregnancy had been an accident. We sat in a private room in the back of Santa Marta Clinic as she explained that she had wanted to keep the baby, but she had recently split up with her boyfriend. She told me that she worked in a frame shop a few blocks from the clinic, earning less than 4,000 pesos a month, and that she couldn't afford another child, and that it would be unfair to bring a child into the world to suffer. She was visibly upset, and I worried that the social workers chiding might have compounded the misgivings she had about ending the pregnancy. But instead, she seemed to agree with the social worker's message. She told me, abortion is a foolish thing we women do. I provoked this. I feel that deep inside. This is my responsibility. So as I was sifting through these findings, hearing over and over in the Ely clinics that patients needed to be more responsible or felt irresponsible, I started to think with scholar sociologist Nicholas Rose, who has identified this term responsibilization, which refers to the construction of responsible subjects as a technology of governance deployed in advanced liberal democracies. And it's a process whereby the problems of problematic individuals are reformulated as moral defects in how people conduct themselves and their existence. So the state and other institutions like churches, schools, and hospitals act from afar to steer human behavior and cultivate self-managing subjects who come to internalize and embody responsible ways of being. And for scholar Nicholas Rose, a defining feature of responsibilization of this process is that it's attached to increased freedoms of individuals, like abortion rights. And responsibilization is a productive frame for analyzing processes of reproductive governance in Mexico, where this notion of responsibility has factored prominently in state efforts to administer reproductive behavior and craft ideal citizens at different historical junctures. So if we look back in time briefly, in the aftermath of the revolution of 1910, reproductive responsibility was central to Mexico's project of post-revolutionary nation building, right? Women's sexual lives and child-rearing techniques came under intensive state scrutiny as women were encouraged to both boost fertility, but also repatriate the nation by responsibly managing the family, the kind of the smallest node of revolutionary nationalism. And despite Mexico's pro-natalist population policy for much of the 20th century, the 1970s are marked by acute panic about the hazards of overpopulation, which was purported to devastate the Mexican economy. And population policy underwent a complete about-face. The state quickly enacted a new policy designed to curb population growth, rolling out massive family planning campaigns that promoted reproductive responsibility, defined by the use of birth control to reduce fertility as a key civic duty. So we see one example more recently on the slide of the Decide con responsabilidad, the Yo Si Me Cuido campaña de 2017. And in the era of legal abortion and state-sanctioned abortion rights, I found that this kind of focus on fomenting reproductive responsibility remains widespread, forming a key aspect of messaging in the Ely clinics, where abortion rights are tethered to responsible reproductive subjectivity. So I'll bring you briefly inside the space of the Ely program. Here is Santa Marta Clinic, a pseudonym where I conducted most of the research. Of course, abortions are provided up to 12 weeks. And Santa Marta, I'm not revealing the location on purpose to protect the identity to the degree possible of the clinicians, but like the other Ely clinics, it's located in a low-income borough characterized by high population density and high rates of poverty. And I recruited abortion patients for interviews in the waiting rooms of Ely clinics, featured on the left of the slide, and conducted interviews in a private room in the back of the clinic. I talked to women about their reproductive lives and histories, their abortion decisions and process, their opinions on abortion legalization, and their experiences in the clinic, among other dynamics. And I interviewed clinicians about their occupational worlds, the stigma that they faced in the broader Secretaría de Salud as abortion providers, some of their frustrations with patients, and why they chose to work in abortion care. And outside of formal interviews, I spent hundreds of hours across Ely clinics in observing dynamics of care, abortion procedures, informational sessions on contraception, and workplace gossip. So this study was grounded in what we might call hospital ethnography. With this audience, I don't need to explain configurations of healthcare in Mexico, but sometimes this is to an audience in a different country who isn't as aware. But of course, the Ely program is housed in La Secretaría de Salud. And this photo on the slide is one that I took just a few blocks from Santa Marta Clinic, the Ely clinic. And it gives you a sense of some of the local complaints in the neighborhood about the public health services offered at the Ely clinic and at the broader Centro de Salud to which it is attached. So exigimos más medicinas y equipo quirúrgico para la clínica. Obviously, there at times was a deficit of supplies. And here's a brief demographic sketch of the Ely clientele. And this is, I updated this yesterday. So to date, over 250,000 publicly funded abortions have been provided through the Ely program. And the number is growing every day. It's remarkable. The Ely clientele is economically diverse, but many women seeking abortion through the public sector are low and middle income. The vast majority, of course, are Mexico City residents. They're young, they hold a high school or middle school degree, or they're in college. And Many are either unemployed, amas de casa, or working in the informal economy, though others have more stable remunerated work. So I'm going to transition now to some of the ethnographic material. Generally, Yle providers did not spontaneously describe abortion as a woman's right. But whenever I asked them directly, all staff members expressed that they respected a woman's decision to decide about her pregnancy and her life, at least under certain circumstances. Roberta, the clinical social worker we met earlier, put it this way. Well, sometimes it's not exactly that you're in favor of abortion, she said. You have to learn to separate that part. You're just orienting the patients that will have abortions. I consider it a job. Patients have abortions, not me. And while Yle personnel agreed that abortion should be an option for women, they didn't generally view abortion as a transcendent right. Instead, for many of the Yle providers, abortion rights were conditional, contingent, and contextual. So while meeting out limited public health resources, the providers grappled with ethical questions about who deserved Yle services and who might be exploiting the program. So their statements about abortion were often tempered by correspondent expectations or conditions on the part of women seeking the procedure. Sara, an Yle doctor, told me, with all rights come obligations. In this case, patients are obligated to prevent this from happening again. For many of the staff, I found that abortion rights were a slippery slope that seemed to portend abuse or exploitation. So circumstantial factors were important in mediating staff support for abortion. So Tony, a nurse, expressed, I'm in favor of abortion among women who were raped or who got pregnant because their birth control failed them. We can concientizar this type of woman, and she can begin to take care of herself after the abortion, because one has to learn her lesson. So abortion rights in this line of moral reasoning seem to more closely resemble privileges, right? They could be retracted when used for the wrong reasons, or too many times, or without careful reflection. And many Yle staff, at least at this clinic, saw abortion as a critical juncture from which to begin a process of moral improvement. So first, oops, ¿qué pasó? Espérame. Aquí va. Aquí vamos. For staff, learning one's lesson implied the effective prevention of subsequent pregnancies through the responsible use of birth control. As one Santa Marta nurse told me, La Secretaría de Salud has two objectives: that Yle procedures are successful and that the patient leaves well-oriented about family planning methods. Once a patient se responsabiliza con un método, there will be fewer abortions. So the providers had this curious role. There was a key tension defining their work. They were providing a service while also trying to limit or prevent people from accessing that service, at least more than once. Roberta, the social worker, told me, we raise awareness in women about sexual and reproductive health, but we don't want to promote abortion no holds barred. Rather, we promote sexual responsibility. We want to prevent that there's so much demand for Yle services. ¿Cómo voy de tiempo, Asunción?
Oh, bien, Elyse.
Bien, ok, perdón.
Tienes 20 minutos más.
Ajá.
Para que haya tiempo para preguntas, comentarios. ¿Está
Perfecto.
bien? Okay.
Perfecto. Gracias. So even as providers try to encourage women to choose or llevar un método, sometimes this task wasn't easy. So they often encourage long-acting methods, the IUD, hormonal injections, or el implante, at times downplaying potential side effects of these methods. But they were frustrated, the clinicians were frustrated that even though the methods were provided for free in the clinic, women didn't often use them reliably, at least in their perspective. So one provider told me, even though you talk to women again and again about methods, they still come back for an abortion. And then you think there's no responsibility on the part of the patient. Sometimes we even ask them, do you not love yourself or what? Why don't you take care of yourself? So one morning at Santa Marta, Roberta and I were receiving patients in the counseling office when a young woman named Sara arrived crying. We reviewed the medical file and noticed that she was seeking her second abortion. And Roberta spoke to her. She said, 2 abortions, que bárbara. She was upset. Sara went on to explain that while she had wanted to get the implant, her husband didn't allow her to use birth control. Sara explained, I feel like he wants to fill me up with kids to feel more secure because he's a lot older than I am. But I can't do this anymore. This is not living. Sara, cambié el pseudonym. Sara wanted a divorce. She had been trying to leave her husband for some time, and her situation underscored some of the circumstantial and interpersonal circumstances that may inhibit women from preventing unwanted pregnancy through birth control, even when they're not trying to get pregnant. So for Sara, seeking an abortion seemed to be a responsible means to control her fertility and manage her family, given the relationship dynamics that circumscribed her options. And while clinicians, they many times recognize certain barriers to contraceptive use in their everyday comments and interactions with patients, they tended to redirect the analytical gaze away from the structural and interpersonal conditions that shape reproductive behavior, instead offering moral or even culturalist explanations for women's quote unquote failure to prevent pregnancy. So as Tony, a nurse, told me, in Mexico, people don't have a culture of taking care of their health. It's always tomorrow, tomorrow, tomorrow. That's what he said.
Wow.
See. For Elyse's staff, repeat abortion represented the clearest example of sexual irresponsibility, and it provoked overwhelming preoccupation and exasperation among Yle personnel. So this theme was ubiquitous in interviews and conversations in the clinic, as personnel providers voiced frustration over patients who, quote, treat abortion like a form of birth control. One social worker told me, what's frustrating is that you counsel them and they come back for an abortion, not once, twice, they come back up to 5 times. We tell them this isn't a joke. We're serious when you say you could become infertile, your uterus could be perforated, you could need a hysterectomy, you could die. So there was a tendency to sort of exaggerate or present a hyperbolic idea about abortion risk, even though complications in the Yle program have been remarkably low. According to data, the rate of complications hovers around 1% to 2%. And of course, we know from medical research all around the world that that first trimester abortion, when performed in an adequate setting, is among the safest medical procedures, right? Far safer than childbirth. So one day in the clinical counseling office, Carolina, another social worker, proposed a practical solution to the problem of repeat abortion. She said, I think one abortion is valid, but when women come 2 or 3 times, we should charge them for the procedure, to concientitarla. And in these cases, we shouldn't just charge for the second abortion, but for the first one too. This way she'll think hard before coming back. And in the clinic, we can recuperate some of the money we spent on her, because it's a lot what the Secretaría de Salud invests in each patient. So data on repeat abortion in the Ely program are no longer available, or at least I haven't been able to find them. They used to be available and now they're not. But in 2015, the rate of second or third abortions was very low, around 5%. And it appeared that the problem of repeat abortion seemed to exist largely in the fears and minds of clinical personnel who worked hard to prevent this outcome. So many of the personnel seemed to view abortion not as an irrevocable right of citizenship that can be exercised without question, but as a contingent service of the state that should not be taken for granted. So at times, patients emerged in this understanding not as rights-bearing citizens, but as individuals prone to carelessness in their sexual lives, or else conniving to exploit the program. And briefly here, my research revealed that oftentimes women absorbed these clinical messages, repeating comments about abortion seeking as evidence of a kind of failed responsibility on their part. Not always, of course. Some women had different perspectives and defended their reproductive choices. But by and large, women themselves, patients, were fearful of repeat abortion as well. One patient told me, there are a lot of women who come for abortions multiple times. That's not okay. I think abortion should be legal, but not for people who are so irresponsible. So they tended to sort of repeat some of the clinical messaging that they received in the clinic. And while there was room for resistance, of course, and some women had more critical stances of the Ely personnel, I found that clinical encounters in the Ely program reinforced pre-existing notions that abortion represented a failure, a personal failure of responsibility to conduct one's reproductive life in accordance with state goals. So how can we make sense of the attitudes or perspectives of Ely personnel? Or what does responsibility mean for these providers? And I struggled with this question for a long time during and after this research. At many times during the research, I was troubled by some of the comments or approach of the Ely providers, but I worked hard to understand and listen to them and their perspective. And I'm convinced that this approach can't be reduced to inward or outward abortion stigma. The providers toiled each day in a pressured labor environment of the clinic for modest compensation. And when many other medical personnel in the public system conscientiously objected, I know Gustavo has written about this, and others were unwilling to work in this environment. And the providers grappled with unrelenting patient demand, with limited resources at their disposal, and they were subject to occupational stigma and critique from other clinicians in La Secretaría de Salud. So the providers told me that other clinicians would refer to them with pejorative terms like espanta cigüeña. And in short, I'm trying to emphasize that this was a taxing job, and they performed it despite contempt from medical colleagues and the broader public. So it may be tempting, and at times it was, to reduce ambivalence on the part of the Ely clinicians to prejudice against abortion or against the largely working class Ely clientele. But I think that's only part of the story. Equally important is an understanding among Ely providers that abortion is a tremendously risky procedure. So while numerous medical studies disprove this assertion, with time I came to see that understandings of abortion risk among Ely personnel extended far beyond medical threats to the physical bodies of their patients. So their understanding of abortion risk was more capacious. It encompassed concerns about the social and moral well-being of the body politic. In a way, providers' understandings of abortion risk were rooted in their valuation of women's more traditional social roles as caretakers and mothers. So one nurse told me, women are very important for the family nucleus. It's rare that a man really supports his kids. If a woman dies, the children are the ones that are going to suffer. So in their perspective, abortion had the potential to unravel families. If a woman died during a procedure, her children would be left without a mother, they often told me. So in short, Ely providers that I interviewed and met did not generally see abortion as an ordinary aspect of reproductive health care or as a transcendent political right to which women were categorically entitled. For them, it was a profoundly risky practice that had the potential to damage women's bodies and also their psyches, tip the balance of the family unit, and ultimately threaten the welfare of Mexican society. So when Ely personnel underscored for their patients the statistically unlikely risks of induced abortion, their objective, I believe, was not to amplify abortion stigma, disciplining women into ideal subjects of biomedical and state control. But their chiding and scolding at times did have this effect. In their professional capacity as healthcare professionals, I believe these workers strove to protect women and the broader society from harms related to abortion that for them felt real and menacing. So when I asked Dr. Rios, a pseudonym, the medical director of Santa Marta Clinic, why she took the job, she told me, I feel very fortunate as a woman, as a person with what I have. And it was exactly for that reason that I said to myself, with all of my privileges, why don't I help those who are unprotected? Dr. Rios beamed proudly during this conversation about her role as the medical director of an Ely clinic. And she said, Ely that we're familiar with from the feminist movement, it seemed to be more about protecting their patients and the broader social whole. And providers felt discouraged when they perceived women to be gambling on their sexual health at the expense of the collective. They sought to create a more utopian society by transmitting their vision of responsibilized citizenship to their patients, whom they hoped would henceforth embody the qualities that providers wanted for the broader social whole. So reigning perspectives in medical and feminist anthropology celebrate reproductive rights, such as abortion, as a hallmark of women's citizenship in liberal societies. And without doubt, abortion legalization and the advent of a public abortion program in Mexico City have expanded reproductive options for hundreds of thousands of women who might otherwise have been unable to access safe, affordable abortion care. But I've shown here that abortion reform is not the end of the story, and that it's important to pay attention to what goes on in the various spaces where people act on abortion rights, and to these micro interactions between abortion providers and their patients, which have much broader political ramifications. So ultimately, while the extension of abortion rights can cleave open new avenues for reproductive health, they can also sort of extend established techniques of reproductive governance, or what some might call reproductive control. And so what I sort of want to emphasize in closing here is that these data might offer a way of thinking about some of the limitations of legal pathways to safeguarding reproductive health and promoting reproductive justice. Thank you. And aquí va el libro por si les interesa, y los agradecimientos. Gracias.
Muchas gracias, Elyse. Y tú dices si quieres continuar en inglés o en español.
En español
Pero,
está bien. En español
pues,
está perfecto.
interesantísimo que nos hagas ver lo que no, bueno, desde luego no queda reflejado en las estadísticas de las que podemos tener conocimiento, sino poner atención a esto, en cómo realmente se da y cómo se transmiten valores y control, en fin. Muchas gracias y queda abierta la discusión. ¿Alguien quiere comentar? Sí, Alma.
Bueno, pues muchas gracias por la presentación. Yo quería preguntarte un poco cómo es que tú piensas que podemos cambiar los prejuicios y toda la, digamos, ideas culturales que tienen en la prestación de servicios de salud sobre la responsabilidad de las mujeres en la sexualidad y en la reproducción. Do I make myself, or should I tell you this in English? Or...
Como sea más fácil.
Sí, so the question is, how can we modify like the gender stereotypes and the idea that women are irresponsible in living their sexuality and seeing again abortion as a contraceptive method, right? Because this is the idea that the doctors in the clinics try to perpetuate or have in their cultural mind.
Sí, gracias. Pues es buena pregunta. Pues en esa entonces, cuando estaba realizando el estudio, estaba en contacto con Fondo María, que también había notado en sus servicios de acompañamiento patrones así como de regaño y así en las clínicas de ILE. Así que no es que sea la única de descubrirlo, digamos, y me imagino que ellos, entre otros grupos, están ya trabajando como para entrenar a los prestadores de servicios que lo hagan de un marco de igualdad de género, de feminismo, digamos. Pero la verdad es que no sé que si tenga la respuesta, y aparte como antropóloga me parece que sería, no sé si sería ética si yo viniendo de otro lugar como que venga con recomendaciones, digamos. Así que creo que más bien en colaboración se lleva a la respuesta, pero unas ideas que se me ocurren son entrenamiento de la perspectiva de igualdad de género para los prestadores de servicios. Igual ustedes tengan una idea de lo que se puede hacer. Lo que intenté yo hacer ahí fue no solo juzgar de una perspectiva extranjera, sino entender la perspectiva, entender bien de dónde venían, dónde estaban parados los prestadores de servicios, o de dónde venían sus ideas de que tener 1 o 2 abortos está mal, ¿no? O viene de una responsabilidad personal y no de estructuras sociales que impiden que las mujeres accedan a métodos anticonceptivos. Así que para cerrar, entender bien de dónde vienen sus perspectivas, tal vez empezar a hacer, a concientizarlas para usar su palabra en una perspectiva que reconozca estas barreras estructurales y la perspectiva de igualdad de género, ¿no? Es lo que diría yo.
Gracias.
Muchas gracias.
Rodolfo, luego Patricia.
Liz, muchas gracias. Esta exposición para mí es un ejemplo de lo que se ha llamado la bioética en contexto, es decir, entender la bioética en el ámbito social, cultural, y nada mejor que esta presentación que nos has hecho para evaluar la importancia de esta interdisciplinariedad que tiene que tener la bioética. Tratando de entender el trabajo que has hecho, Elyse, yo creo que atrás de tu trabajo también debe haber alguna preconcepción teórica tuya para poder acercarte. Yo sé que los antropólogos tienen que mantener una actitud más neutral, pero obviamente cuando dices tú que habría que educar en la igualdad de género o en los derechos humanos, tú asumes quizás una posición más liberal con respecto al tratamiento. Y yo creo que una forma también de ayudar a las que proveen estos servicios es mostrarles que atrás también hay preconcepciones, es decir, podría tener una preconcepción más comunitarista o una preconcepción más pluricultural o muy liberal, en fin. Por supuesto habría que usar otros términos, pero yo creo que no está de más que este aspecto más conceptual, más teórico, también se haga visible, porque si no podemos asumir como una especie de reforzamiento del statu quo. Así es como actúan y así debe de ser. Y yo creo que no, yo creo que hay que ser más críticos en ese punto, ¿no? No sé cuál es tu reacción, Elyse, a esto.
Sí, haces buen punto. ¿Me podrías decir o como que reformular un poco la última pregunta?
Sí, you can take some theories behind this approach, this anthropological approach.
Sí.
And some of these perspectives are liberal, some others are communitarians, and others are multicultural. So I think you cannot be neutral when you make your research about this. And I think you have a theory. I think your theory is a liberal theory.
Claro, gracias. Sí, es que yo luché mucho con estos hallazgos, ¿no? Por varias razones, pero sí, y en el libro que quedó del proyecto, explico dónde estoy parado yo en cuestiones del aborto, ¿no? Cuál es mi posición, de dónde vengo, el contexto cultural, dónde vengo, y mis perspectivas políticas, éticas acerca del aborto, que si no es claro, que soy, digamos, pro elegir, ¿no? Y esto, como todos los antropólogos, estoy abierta y lo quiero, y quiero presentar dónde estoy parado, ¿no? En ese sentido. Pero lo que intenté hacer ahí fue no solo imponer mi perspectiva lejana o política o ética, sino entender su posición, ¿no? de los proveedores en este tema, y tanto los de las mujeres, que varias varias de las mujeres también decían que ellas mismas fueron irresponsables, que habían fallado y así. No todos, obviamente. No sé si eso, no sé si, o sea, querías mi reacción, no sé si contesto así la pregunta,
Luego, un
Rodolfo.
minutito nada más.
Claro.
A mí lo que me es
Sí.
visible es las concepciones
Sí.
y se asume una visión tan descriptivista y neutral como orientación para las proveedoras, podemos curiosamente reforzar una teoría, que sería una teoría conservadora, reforzar el Estado. Que preocupa a veces, ¿no? Entiendo tu trabajo descriptivo, pero me parece que cuando ya se trabaja con las operadoras, mantener esa actitud neutral puede reforzar situaciones statu quo. Ese es
Sí,
mi punto.
ya. Sí, es buen punto, es buen punto. Tendrás que leer el libro
Sí,
y averiguar si lo hago ahí o no.
Seguro lo haré, seguro lo haré.
No,
Gracias,
pero
gracias.
es buen punto, es buen punto.
Patricio.
Muchas gracias, Elyse.
Hola.
Hola, me interesó esto de la política de gobernanza, de la responsabilización, y yo lo interpreto como un fenómeno que se da frecuentemente en medicina, que es que deviene, o sea, lleva a pensar en una administración a través de la culpa de distintas situaciones, no nada más en la interrupción del embarazo, sino en otras situaciones médicas, lo que muchos llaman victimización de la víctima, el victim blaming. ¿Sí? Y ves que es una actitud del personal, como que sienten la obligación de hacer algo para contrarrestar el deseo de la mujer a recibir un servicio al que tiene derecho. Y yo no sé si eso, sin duda, está dentro de la misma política establecida. Y ¿a ti qué te parece qué tanto influye aspectos como lo que, no sé, se me ocurre llamarle racionalización religiosa, para dejar entrever las bases religiosas del personal que están ahí en el fondo y que finalmente pues quieren demostrar que no están cometiendo pecados, por decirlo así. O la otra posibilidad es y que es muy real, es que hay mucha presión de los grupos pro vida, para que se den políticas de que se haga explícito el riesgo al que se someten las mujeres y que se les den alternativas antes de hacer el procedimiento. Y esa es una parte. Y la otra tiene que ver con esto último, porque tú mencionas 250,000 interrupciones del embarazo, que yo insistiría en que debemos de usar el término interrupción del embarazo y no aborto, porque el aborto conlleva una imagen muy negativa en la sociedad. Y la verdad es que hasta donde tengo entendido, 98% o más de esas 250,000 interrupciones han sido con pastillas, en donde el riesgo es mínimo. La mortalidad, creo que hasta donde sé es una paciente que ha fallecido, y las otras 249,000 no ha habido mortalidad. hay cierto grado de morbilidad transitoria, ¿sí? Y hay otros métodos. No sé cómo estén las estadísticas ahorita, pero uno pensaría que si compara uno el riesgo de la interrupción del embarazo, la interrupción farmacológica del embarazo, con los riesgos de varios años de tomar anticonceptivos u otros hormonales, otros métodos, en cuanto a una serie de cosas, síndromes de hipercoagulabilidad, problemas de trombosis venosas, problemas de riesgo de cáncer de mama de otras neoplasias femeninas. Creo que el riesgo de incluso usar la interrupción del embarazo como método anticonceptivo no se vuelve argumento, y creo que el personal debería de conocer estas cosas, forma de cambiar la actitud ante el
Claro,
procedimiento.
gracias.
Gracias.
Igual enseñarles las estadísticas y las nociones biomédicas del riesgo de aborto, que como dice bien, es bien bajito, puede cambiar esa mentalidad que tengan de hyperbolizing abortion risk, de lo que decía. Y sí, respondiendo tantito, la racionalización religiosa, como dices, entre personal o prestadores de servicio, salía a veces, obviamente incluso cuando no se identificaban religiosas, ¿no? Está ahí metido en el ámbito entre prestadores y entre las mujeres que acceden a la ILE. ¿Y qué más? En cuanto a las estadísticas, pues sí, creo que sacas una buena respuesta a la pregunta de Alma al principio, de cómo cambiar las actitudes y prejuicios y mentalidades, así con el simple dar la información correcta de lo que es el riesgo y que es muy bajo en la actualidad. Se me ocurre que esa parte al final de la ponencia, cuando intenté entender las perspectivas de las prestadores de servicios, causó alarma, ¿no? Y no es que sea crítica de su perspectiva, obviamente a través de todo el estudio, así sentía enojada y así, y lo hablaba con Fondo María y otras personas que están metidas en este ámbito de la ILE. Pero como pivot o move venía más de la perspectiva antropológica, que no es neutral, sino que entienda o intenta más bien contextualizar respuestas y perspectivas aun cuando nos ofendan. Pero no es que diga yo que esté bien, que así perpetúan perspectivas que causan daño, ¿no? O estigma y así. Pero bueno, está interesante la discusión.
Gracias, Bernardo.
Muchas gracias. Por tratar de confirmar un término antes de preguntar, fui y encontré la página del Instituto Nacional de Salud Pública relacionada con la violencia obstétrica.
Ya.
Nos ayudaría que fuera incluida, porque las encuestas de violencia obstétrica están referidas únicamente a embarazo, parto y puerperio. ¿No debería también de incluirse para capacitar y prevenirlo? Es decir, si se incorpora en la estadística también serviría. Porque hay una estadística que hace el Instituto Nacional de Salud Pública y también el INEGI.
Claro, gracias.
Do you want me to do it again in English or is?
Creo que sí, creo que perdí
Okay.
la pregunta.
Just to clarify some concept, I review the net and watch over obstetric violence.
Sí.
And it's referred just for pregnancy and to delivering, not according for abortion. And maybe if we change and include also for abortion as this kind of violence can maybe modify attitudes from people, and is national survey for the National Institute of Public Health that reveals it.
Ya entendí. Sí, estoy de acuerdo. Sí, el concepto de violencia obstétrica suele ser asociada con embarazo y parto, y no se aplica, de lo que he visto yo, no se aplica al aborto o interacciones que ocurren en las clínicas de aborto. Tocó el tema un poco en un capítulo acá de la violencia obstétrica y sí, pero sí es buen punto que se tiene que amplificar este término para incluir el aborto también, porque no es solo que tengan el derecho y lo tienen gratuito, sino que hay dinámicas pasando ahí en estos encuentros clínicos que se puede llamar violento, ¿no? O violencia obstétrica.
Muchas gracias.
A usted.
Rodolfo, otra vez.
Sí, nada más pensando en la pregunta que había hecho Patricio, Elyse, una de las cosas que un liberal más ataja o más critica es la visión paternalista que asume los médicos, o que en este caso pudieran asumir las proveedoras de servicio, ¿no? Y yo creo que no hay que perder de vista la perspectiva de que son personas adultas las que van a decidir, y uno asume también que son competentes para decidir. Puede haber un tono ahí como de falta de conocimiento, de inmadurez, de infantilidad. Todo esto me parece muy peligroso cuando alguien quiere asumir una posición más liberal, en el sentido de cuidado con el paternalismo. Esto me preocupa muchísimo, ¿no? Y creo que una de las formas de instruir a las proveedoras es saber escuchar, presentar opciones, pero en ningún sentido tomar una decisión casi como en lugar de la persona, es decir, ni orientarla siquiera, ¿no? Pero bueno, en fin, esto otra vez me preocupa desde la visión liberal, que seamos muy propensos a una visión paternal o incluso perfeccionista, es decir, queremos que tengan un mejor carácter, que sean mejores ciudadanas. En fin, todo esto me parece terrible, ¿no? Si llegara a promoverse, ¿no? Are you agree about this?
Sí.
Yo sobre este comentario, perdón.
No, adelante. Mina,
¿Quieres
adelante.
comentar, Elyse? Y luego escuchamos a Mina y a Patti.
Sí, pero es que una duda, es que Rodolfo dice que lo que te preocupa es la actitud paternalista de los prestadores o de mi parte.
De los prestadores.
Ay, perdón. Okay. Qué bien. Porque cambia cómo voy a responder. No, sí, no, estoy totalmente de acuerdo. Sí, este paternalismo. Sí, para mí me parece bastante problemático, ¿no?
O mejores personas, que te digan, vamos a ser mejores personas. No, tampoco.
Responsables, no.
Responsables, sí. Nunca dijeron que sean mejores personas, implicaron en sus mensajes, ¿no? Que se tendrían que concienciar cambiar moralmente, bueno, o la nivel moral como que la puse yo, analizando lo que decía su discurso. Pero sí, el paternalismo estaba muy presente. Bueno, las decían chicas, para empezar, no mujeres, así, chicas. Y bueno, había más citas que ni incluyen la presentación por falta de tiempo. Pero Mina, a ver, que decía la mano,
Sí, no.
tenía la
Y
mano.
luego
Mi
Pati.
comentario es que en general, en el ámbito de la medicina, de los estudiantes de medicina, de las mujeres que desarrollan esta labor, se tiene que promover más la bioética, porque de cuando acá el paternalismo que ha prevalecido durante tantísimos años va a desaparecer por muy buenas intenciones que pudieras tener. Entonces, no creo que le corresponda solamente a los usuarios, le corresponde sobre todo a la Secretaría de Salud, a los programas de educación en las universidades donde se imparte la carrera de medicina, porque esta cuestión de la violencia obstétrica es muy generalizada y ¿cómo la vamos a evitar si no es educando a los ginecólogos o prestadores de servicios para el aborto a que no tengan esa actitud? Creo allí sí el ámbito de la educación es fundamental y los programas educativos en las facultades de medicina carecen de estas visiones que proporciona la bioética. ¿No?
Gracias. Sí.
Bueno, y muchas gracias, Elyse, por darnos esta perspectiva desde dentro y desde tan cerca de las usuarias y de las prestadoras y prestadores del servicio.
Gracias.
Pati, yo creo que va a ser la última para cerrar. Pati.
Gracias, muchas gracias, Elyse. Me encantó tu presentación. Como todos sabemos, ninguna mujer quiere abortar. No va porque es algo lindo ni le pasa nada. Llega ahí con culpa, sintiéndose mal, como, pienso yo, con muchos sentimientos encontrados incluso, pero no llega en buen estado ahí. Y lo que vemos es solo la puntita del iceberg de toda la problemática que hay atrás, que no estamos revisando. Interrumpir el embarazo no es ni bueno ni malo, pero cuando llegan ahí pueden llegar con una carga muy importante de toda la problemática familiar y social que están viviendo, y sería una gran oportunidad poder sembrar una semillita ahí de apertura a todos esos conflictos que hay detrás de una mujer que llega a solicitar la interrupción del embarazo, que sería como todo un tema. Pero por otro lado, del lado médico, de enfermería, de trabajo social, me parece, si bien no estoy de acuerdo, me parece muy lógico que actúen así, porque ellas tienen que defenderse de su medio, de su propio medio. ¿Cómo justifico con mi familia, con mi sociedad, con mis vecinos que yo trabajo en esa clínica? Ah, bueno, yo voy porque yo les digo que lo que hacen está mal y que se tienen que responsabilizar y que tienen que ser buenas. Yo voy como mensajera de la moralidad y de las buenas costumbres y de lo que debe ser y demás. Por eso estoy ahí, no porque estoy respetando los derechos de las mujeres que abortan, ¿no? Un poquito así. Y faltaría como tener, sí, lineamientos de qué es lo que debemos decir, qué es lo que debemos buscar en esas clínicas. ¿Cómo me entrevisto con una mujer que está solicitando la interrupción del embarazo? ¿Desde qué perspectiva? Desde luego, como si el personal está consciente que esto no es ni bueno ni malo, no es que estás arriesgando la vida por venir aquí, no es que tú no estás pensando, no es que tú eres irresponsable, no es que, o sea, sino estás ante una situación en donde hay que hacer una resolución, pero también me da la oportunidad de abrir para poder presentar alternativas de solución un poquito para los problemas que hay detrás de la mujer que viene a solicitar el servicio. Entonces, creo que me parece muy razonable y muy explicable lo que pasa, aunque no considero que no es lo que debería de ser.
Claro.
Gracias, Elyse.
Sí, a ustedes.
Elyse,
Sí.
pues, ¿quieres comentar algo? No comenta al respecto porque creo que es interesante lo que señala Pati.
Pues sí, solo brevemente, un ejemplo, por ejemplo, este doctora Ríos, que no es su nombre, realmente decía que tenía dos hijos, vivía ahí en el barrio y me decía que era, bueno, que no decía a sus familiares, sí, pero a sus amigos, al ámbito social, no les decía dónde trabajaba, sino que era médica, ¿no? Justo porque los juzgamientos el juzgo de los demás. Y aparte porque tenía hijos en la escuela y no quería que los otros niños, que les afectara a sus hijos en la escuela. Así que lo que dices me parece interesante que se justifican ellas mismas o ellos mismos, mismos, el trabajo que realizan, aunque fundamentalmente they're ambivalent, o como un choque de la conciencia de lo que hacen, ¿no? Lo que más me afectó de este trabajo es que llegando ahí, imaginé del contexto estadounidense, imaginé que los prestadores serían pro elegir y lo que encontré fue algo mucho más complicado.
Sí. Con ambivalencia, señalas muy bien esa ambivalencia.
Muchas gracias.
Muchísimas gracias, Elyse. Estamos invitadísimos a leer tu libro para tener toda la explicación mucho más amplia y tu experiencia, pero sí nos quedamos con un acercamiento muy, muy importante a algo que nos interesa muchísimo y que había que tener esta perspectiva más amplia. Así que muchas, muchas gracias y muchas gracias a todos también por los comentarios que enriquecieron esto.
Muchas gracias.
Gracias.
Hasta
Nos
luego.
vemos pronto.
Estamos en contacto, Liz, y nos vemos pronto
Gracias,
todos.
Elyse.
Chao.
Muchas gracias. Buena semana.
Gracias. Hasta Barcelona.